broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. Or should I say, good morning, buzzards. That was Journey that you just heard, and some of our songs today will be by Journey, but we'll run out of Journey songs, and then we'll do a little bit of Phil Collins with his awesome band, Genesis. And I'm Dr. Minarsik, and today is December 21st, which means this is Christmas week. So today, Tuesday, and on the 23rd, Thursday, we're going to be having Christmas lights, which I put up. I know that you really like them, okay? I really do too. We're going to talk about more respiratory tract diseases today. If you remember, we scheduled 4 webinars for respiratory tract diseases, and we've already given one, and that was the upper respiratory tract, okay, everything above the lung. So in the next 3, we're going to go everywhere in and below the lung. And today we'll actually be dealing with pulmonary diseases that are not classical pneumonias, and they are not tumors either. And then probably next in a couple of days, in 48 hours from now, Thursday, we'll be dealing with pneumonias. And then in the 4th one, we'll be dealing with lung tumors, and we're going to have a lab as well, because we're about due for a good old virtual microscopy lab for the histopathology of the things we'll be talking about. I don't think I really have anything else to say. I hope you like my Christmas lights. I was also hoping somebody would make a comment about the Christmas lights, that they like them or something like that in the question box, just so I know that you're hearing me. I can see by the numbers that you're there, but if you make a nice little comment, I'll be very relaxed. Like I'm not relaxed already. Okay, let's drop down the ugly guy and put up the PowerPoints and see what we could do today. The lung. I bet you've never seen a picture of it like this before. It's actually kind of like a freeze-dried prep, done very, very well. And up here you have a scanning electron micrograph of it, down to the point where you could see an actual alveolus, an air sac, a terminal air sac, surrounded by the alveolar septum and the capillaries in it. Okay? I thought that would make a good opening picture, but we're going to go into it in more detail. So, as always, now that we are in the lower respiratory tract, or the lung, we're going to be talking about the so-called degenerative, maybe congenital diseases, the inflammatory diseases, the classical pneumonias, and the neoplastic diseases with the lab in the 4th and very, very last webinar. So, today, this is our overview. We'll be talking a little bit about a review of normal overall anatomy and histology. You should be an expert in that already, but you may have forgotten a few little details. Then we'll talk about some items here, some of the common congenital diseases of the lower respiratory tract, the concept of atelectasis and what causes it, acute pulmonary injury, and a lot of these may show inflammatory changes, but they're not classical pneumonias. Then we're going to go into the concepts, the physiologic, the pathophysiologic concepts of the obstructive pulmonary diseases versus the restrictive. What is obstructive lung disease? Is it an obstruction of a vessel or an airway? Is it an obstruction of inspiration or expiration? Concepts like that. And then a restrictive, which is a little bit more involved of a definition and has a wide variety of things. I myself have a pretty good restrictive lung disease following my big COVID infection about a year ago. And we'll talk about the obstructive pulmonary diseases, the restrictive ones. We're going to go into a pretty big list, and some of them, common ones, will go into great detail. Finally, the vascular pulmonary diseases, okay? So let's hit it. Okay, and then in the next webinar, we'll talk about infections or pneumonias, so to speak. And then in the fourth and final webinar, a week from today, we'll talk about neoplasms and have a nice good old-fashioned histopathology lab, which I know you love. Here's kind of like a similar picture to what we saw in the opening thing. You know, the normal weight of a lung is about 1,000 grams. Well, that's a nice round figure. And you know the right is bigger than the left a little bit, so actually it boils down to about 550 and 450. And you know that the trachea has a main stem bronchus on the left and right, which have secondary and tertiary branches and so forth. And the arteries actually follow the bronchi, generally speaking. However, the veins have an independent course separate from the bronchi as well. That's something that you should know. Now, you should also know, from point of view of pathology or pathologists, two very important words. One of them we use all the time. It's called smooth and glistening. That means when you look at the lungs, you know, at surgery or at autopsy, you know, the pleural surface is glistening and smooth. It's not rough. It doesn't have bumps. It kind of has a nice little light that shines back at you. And that's very, very important, because just about any disease involving this peripheral area would show as an interruption in smooth and glistening in the pleural surfaces. The other big word, which you should really, really understand, it's a pathologic term, and it's called crepitence. Actually, I have the word down here somewhere. Here it is, crepitence. We'll put that in bold letters and underline it, because it's very, very important. Whoops, forgot the E. So let's do that in bold and underline also. Crepitence is the, oh, I just screwed that up. Yeah, there we go. Let's see if it works this time. Bold and underlined. Okay, crepitence is the amount of bubbliness. I guess that's the best general word to use. In other words, when you're doing surgery or you're at autopsy, and it's even related to the radiology, you have to feel the air bubbles inside the lung when you squeeze it. Okay, that's crepitence. So if a lung loses crepitence, that means that something has filled up those air spaces, like maybe tumor, like maybe pneumonia, like maybe fluid, okay? So that's an important concept. And probably the word crepitence is on every pathology report or autopsy report that you'll ever see. 3 lobes on the right, 2 on the left. Then we have the lobes divided into bronchopulmonary segments, depending on, they have a variety of names. Okay, these bronchopulmonary segments are fed by bronchi and the arteries which run with them. However, a vein runs separate from the bronchopulmonary distribution. The part of the lung that you can see on the surface is the visceral pleura. The part of the smooth and glistening pleural mesothelial line surface in the chest wall is the parietal pleura. And then you can see its normal distribution of tiny nerves, which really you probably can't see, okay? But they're basically distributed to where they have to be distributed also. This is probably the single best histopic of the lung I've ever seen. It's something from the slide collection that we have from the University of Iowa. There's basically 2 things to the lung histology: the blood spaces and the air spaces, okay? The air spaces are the bronchi, and when the bronchi lose their cartilage, and then they're called bronchioles. And then when the bronchioles become ultimately so small that they're just lined by a septum and a capillary surrounding an air sac, of course, that's the smallest level of air spaces, which is the alveolus, or alveoli is the plural. Those are lined by type 1 pneumocytes. There's a few cells roaming around called the type 2, which contain the surfactant. Macrophages also patrol the lung throughout the septum as well. And of course, each of these tiniest of tiny holes is a little sac surrounded by many, probably 20, 30, capillaries as well. Okay. what more can we see? I think you should keep that simplistic attitude in your mind. And one thing I'll say more about the air spaces is that they basically flatten as they go deeper into the lung and more peripheral. So, of course, they're pseudostratified ciliated columnar at the highest level, like the trachea and bronchi, then flattening out to cuboidal. Then, of course, technically, the epithelium, or the type 1 pneumocytes, has been described as a single, flat, tiny squamous layer, okay? Here we go. Here is your capillary lumen. This whole thing here is an alveolar wall, or septae, so to speak. Here is your endothelial cell nucleus. This little orange band is your endothelial cytoplasm. On the other side of it, of course, is your type 1 endothelium, which is the lowest level of epithelium surrounding the lung. Here are your type 2 with these little dots here. They're not, you might think they're macrophages, and there are macrophages in the lung which kind of control various parts, but the type 2 epithelium might be what they call type 2 pneumocytes, may be mistaken for one because they have these little granules, which are the surfactants, which of course your lung needs for very, very smooth operation. Here at the smallest level, we saw this in a previous picture where we see the M is an actual alveolus, and these the wall that surrounds it, these tiny, tiny, tiny holes are of course the capillaries. So where is the air transfer taking place? Well, you see this guy down here? That's a red blood cell. It's the edge of a red blood cell. So this is a capillary lumen, and therefore this has to be an endothelial cell, right? Now you have technically a basement membrane between the endothelial cell and the cytoplasm of the type 1 pneumocyte, okay, or type 1 epithelium, they call it. There are also a few scattered interstitial cells, mostly fibroblasts, and they should not be too common. Of course, after a pulmonary infection, especially a viral infection, they can become very, very numerous and be part of this picture of pulmonary fibrosis, which we'll be talking about. Okay, let's see what we got down here now. Embryologically speaking, you know, the tracheobronchial tree as well as the foregut, esophagus part of the foregut, is a derivation of the foregut, the entoderm, and of course, eventually they separate, okay? Sometimes there's a fistula between the two, which is the most common type of pulmonary congenital anomaly, but the trachea and bronchi ultimately is anterior to the esophagus, okay? And remember, it is the right lung, not only is the one that has the 3 lobes, but it is the primary one. The primary budding of the lung continues into the right, and then the left branches off. And that's why when you see a kid in the emergency room because he swallowed a penny or something like that, it's most likely it's lodged in the right lung most of the time, simply because that's the one that has the most direct route driven by gravity. The left one always comes out a little bit more, and that persists even into the adult stage as well. This is a normal chest x-ray. You can see the heart shadow. You can see the lung fields. You can see the diaphragm on the right and left. Of course, the liver being here, the spleen probably being here. The main feature that the radiologist and what you should be looking for is lucency. Any type of lucency, okay? The lung fields should be lucent. They should be developed well enough because you can see differentiation from the ribs. You have to have good eyes. If there is a small infiltrate, that's an interruption of the lucency. And if you don't know anything about chest x-rays at all, or if you haven't read a million chest x-ray reports, probably the main thing that a radiologist looks for is this concept of an infiltrate. Because an infiltrate in the lung, no matter where it is, means that there is a loss of lung air tissue. Could that be patch of inflammation? Could it be fluid? Could it be a tumor? Could it be a foreign body? Could it be granuloma? But this is what we would also describe in the pathology lab as a loss of crepitance. So what the radiologist describes as an infiltrate, the pathologist might feel at autopsy before he even cuts it as a loss of crepitance. And of course, it's also very, very important to look at these costophrenic angles. There's the ribs and there's the diaphragm. That's why they call it costophrenic, to see if they're nice and sharp. You see how they come to a nice point over here and over here? Because if there's any fluid that is in the lung, it's probably going to collect, gravitationally speaking, if the patient's standing up, of course, at this little costophrenic angle. Okay, and there's a million other things that the radiologists, look for: the pulmonary vasculature, the loss of vasculature. But from the point of view of a regular doctor going up to radiology to look at his patient's x-rays, you're basically looking to see if they are clear. In other words, no infiltrates or not. And probably the single best term, which is often used quickly by radiologists to describe a so-called normal chest x-ray, would be a word like no infiltrates, or no active infiltrates, or no new infiltrates. That's the main thing you're looking for. You have to understand this concept of infiltrate. Okay, so here we are. And we're going to run over today these non-pneumonia, generally non-neoplastic diseases, starting out with some of the common congenital ones and dealing with the concept. Atelectasis is not a disease, it's a finding, okay? Then we're going to talk about various types of acute pulmonary injury. Then we'll go into the concept of obstructive lung diseases versus restrictive lung diseases. And if you could divide almost all lung disease into pathophysiologic groups, you would say there's only two kinds of pulmonary diseases: the obstructive and the restrictive. And many of the diseases have features of both, of course. But remember, the restrictive ones are characterized by loss of lucency or increase in density, what we might call infiltrative diseases. Then we'll go into the single most common and highest mortality lung disease, chronic, we'll call it obstructive lung disease, okay? But very often it's called chronic obstructive disease because most of the obstructive lung diseases follow a chronic course. Then we'll run down this concept of the infiltrative. And remember, pneumonias could be infiltrates as well, but they don't generally, and they will have restrictive findings when you do pulmonary function tests. But the infiltrative lung diseases are basically also known more or less as their restrictive lung diseases. Why? Because if you have an infiltrate, especially diffuse infiltrates, they interfere with gas transfer, and that's probably the single biggest physiologic or pathophysiologic concept in the restrictive pulmonary diseases. But there's even a better single concept in the restrictive diseases. Why are they called restrictive? Well, if you have a sponge and it doesn't squeeze nicely when you squeeze it, it's being restricted from squeezing, right? So they call that compliance. The restrictive pulmonary diseases are often described as infiltrated, but the one word that characterizes them is loss of compliance. If you don't have a normal lung, it doesn't move the way it should when you squeeze it or when it is physiologically moved during inspiration and expiration. And we'll talk about the common vascular pulmonary diseases. You probably know that pulmonary embolism is one, and we've already described pulmonary emboli twice, okay? But we're going to talk about it in more detail now. What could go wrong in embryology? Well, is it possible that the lungs never develop at all? Or one doesn't develop at all? Yeah, that's called agenesis. That's very rare. You'll probably never see it. And of course, it's probably not going to be compatible with life. So not too many kids or adults could walk around with that diagnosis. Perhaps it may develop just a little bit, but not very much. That could be called hypoplastic lungs, okay? That's another congenital anomaly that, quite frankly, I don't think I've ever seen either of these two. The one that is, without a doubt, the most common, and if you remember, we said that embryologically, the foregut gives rise to two tubes. One of them is called the trachea, that's the T, and the other one is called the esophagus, that's the E. Technically, whoops, I can't believe I did that. Technically, those tubes should be independent tubes and they should not connect with each other, okay? Well, sometimes they do because of some type of developmental anomaly, and that's called a TE fistula. And geometrically speaking, there might be about 5 or 6 different possibilities, but there's only one that's the predominant one, which is most of the time, okay? Could you have vascular anomalies? Of course you can have vascular anomalies anywhere. We talked about AVMs, we talk about the blood vessels not developing properly, and that's a possibility. Could you have something called congenital emphysema? Okay, yes you can, even though most emphysema is in adults, and it's in adults that have followed a course of chronic bronchitis and or asthma or other diseases which obstructs the small airways. You could also be born with it as well. Foregut cysts. Of course that's possible because the foregut gives rise to those two tubes, trachea and esophagus, which travel inferiorly in developmental anatomy, but they could have some cystic remnants along the way. Okay, we're not going to go into that in any further detail. Could you have malformations of the pulmonary artery? Of course you can, just like we talked about a whole wide variety of congenital malformations of the aorta in the last topic. That can also happen in the pulmonary artery. Some of them are in association with the aorta because they both develop from the so-called conus, or some of them could just be primarily pulmonary artery malformations. These are all, I hope, logical, because I'm not going to go into the details of any of them except for the TE fistulas, which are without a doubt the most common. Now, what is the concept of sequestration? Well, as you know, lungs ultimately, functional lung tissue should connect to the outside air, okay? But what if it doesn't? What if there's something in development that cuts that off, okay? Then that's called pulmonary sequestration, a portion of lung in which there is no air connecting to the larger airways. You would think that that portion of the lung probably wouldn't have air in it either, would it? Okay? Well, that's the concept of a congenital anomaly. And all these are rare, called sequestration. However, let's talk about the one that's probably 10 times more common than all the rest of them. These are the TE fistulas. Here we have the trachea traveling inferiorly. We're now in the lower respiratory tract. We got the main left and right bronchi. And you should now have another tube also coming from the foregut called the esophagus. Could you have a constricture of the esophagus? Yes, that is considered one of the types of TE fistula, but it's really not a fistula because there's no connection between the food channel and the air channel. So that's just called esophageal atresia. Okay, could esophageal atresia be preceded, or perhaps could there be a variant of it just called esophageal stenosis? Of course, because atresia is nothing more than complete stenosis or complete blockage. Now, here are the types of fistulas, just geometrically speaking. The food tube could enter the trachea, and then the inferior portion of the food tube could be a blind pocket. Or you could have both the upper portion of the esophagus as well as the lower, both connecting into the trachea. Or the other geometric possibility would be, what's the remaining thing, is to have the upper part of the esophagus, not being a blind pocket, and the lower part entering into the esophagus. I'm sorry, the trachea. And that's what it is most of the time. So a baby with a TE fistula, for example, won't be able to get the food down, and the airway will actually connect into the lower esophagus. Okay, these can be repaired. I don't know much about the surgery of it. Or technically, could you have a fistula, okay, where you have simply a direct connection between the trachea and the esophagus without any narrowing or blockage or atresia of the esophagus? Yes, that's possible also, but it's rare. So when you rotate through OB and you hear that a baby has a TE fistula, which you might, because it's not that uncommon, you're going to know that most of the time you got a baby that can't get the food down. That's because the upper part of the esophagus is blocked or atretic, and the lower part most likely connects into the trachea. So let's talk about another concept now that we finished the common congenital possibilities. Let's talk about atelectasis. Atelectasis is not a disease. Atelectasis is simply a phenomenon where a part of the lung collapses. Probably a good word to say that is almost identical to atelectasis is pulmonary collapsing, okay? In other words, when a part of the lung collapses, there's no air in it, okay? Why would that happen? Well, when you think about it, it's not just medicine, it's not pathology, it's almost geometry or normal. If a part of the lung collapses, like here in the upper lobe, it's possible that the bronchus that feeds that portion of lung is obstructed. Now let me ask you this. If a portion of a bronchus or even a bronchiole is completely obstructed, then that portion of lung that it feeds won't be able to ventilate, okay? So eventually the air gets reabsorbed and the lung collapses. That's probably one of the most common concepts in atelectasis, and when there's been a blockage of a bronchus, a complete blockage. What would do that? How about a tumor, okay? But technically any complete blockage would meet the pathophysiologic criteria. Now, but what happens now if there's a lot of fluid at the base of the lung? And that fluid pushes the lung or squeezes that sponge to where it squeezes all the air out of it. Then that portion of the lung, because of compression from a pleural phenomenon, fluid most likely, but maybe a mesothelioma or any pleural mass could do this. That's a second pathophysiologic concept of atelectasis. Now, the third one is also, I hope, kind of logical. We talked about the fact that there are fibroblasts in the lung, and there could be lung or pulmonary conditions in which there's been inflammation or even not inflammation, where you have a significant amount of fibrosis in the lung. And what do scars do? Scars or fibrous tissue contract. So if a fibrotic lung, and there's a wide variety of fibrotic pulmonary diseases we're going to talk about, if a scar contracts, then the tissue of the lung will contract with it and lose its air spaces, or so-called collapse. I guess that's the best word, okay? They also have the concept of incomplete expansion, but practically speaking, the word or the concept of collapse is even more common when you talk about atelectasis. And as you can see, it's not a single disease. It could be related to a wide variety of pathophysiologic conditions. Okay, we talked about congenital lung diseases. We talked about atelectasis. Let's talk about acute pulmonary injury. Now, what I want to say here is look at one of these things is something they call pneumonia. And in some of these, you're going to have increase in cells. Now, that in itself is not pneumonia. We talk about pneumonia, we're basically talking about bacteria, viruses, fungi, whatever, causing an inflammatory reaction. Even though something called acute interstitial pneumonia, is not classically an infectious pneumonia. It's still considered more part of acute pulmonary injury, because we're going to be talking about the pneumonias in the next webinar. Well, here's the first level of pulmonary injury. What happens when you have a heart failure? Well, when you have heart failure, the venous return to your heart, left or right ventricle, cannot keep up with the outflow. Okay, so let's say you have a left ventricle that can't pump out all the blood that's given to it through the left atrium, and therefore the pulmonary veins. Okay, so what happens? The pulmonary veins increase in pressure. Now, technically, you can also have pulmonary edema simply if you have a decreased oncotic pressure. That's one of the key concepts in edema anywhere, not just the lungs. In other words, you don't have enough protein content, mostly albumin, to keep that fluid within the vascular space, and therefore it goes out of the vascular space into the extracellular space, which in the lung, an extracellular space could very easily be the alveoli. So, if you had a lymphatic obstruction from the lymphatics of the lung, you would have the same type of phenomenon, wouldn't you? You'd have increased pressure. We have increased or decreased ability to drain the extracellular fluid, and that builds up and goes into the lungs, or we'll say into the alveoli. Now, technically, you could have an edema from an alveolar injury as well. However, if you have an actual alveolar injury, it's probably not just going to be pure watery fluid that fills up those alveoli. It's probably going to be inflammatory cells and blood cells and so forth. Now, from a histologic point of view, if you wanted to describe pulmonary edema histologically, you say it looks like a normal lung, except there's water. Not too much by way of cells, but mostly watery, transudate, not exudate. The exudate is an inflammatory fluid. Transudate is, excuse me, pretty much pure watery fluid with a low specific gravity, low number of cells. So if this is a normal lung, you take that normal lung, or maybe you could say, hey, this is not normal. There's a lot of congestion. There's a lot of cells in those alveolar capillaries. That's why the septae around the alveoli look very red. This is classical pulmonary edema. Let's make it easy for you. Normal looking lung, but rather than air in the alveoli, you have pretty much water. Now, but what happened if you just have a lung that's injured? Perhaps it's an infection. Perhaps there's been a physical traumatic injury. Perhaps there's been a toxic compounds that's toxic to the lungs, or chemicals, or shock, okay? DIC with shock, and where there's a diffuse coagulation. Okay, this is basically your differential diagnosis of acute pulmonary injury. Some people call it ARDS, for adult respiratory distress syndrome. If you remember, or you will know, that babies who are born prematurely and they don't have enough surfactant get RDS, neonatal. So neonatal RDS looks very, very much like adult RDS, and that's why it's called ARDS. Another name for it is DAD, because that's basically diffuse alveolar damage. If you have diffuse alveolar damage, not just from shock, but any of these things, you might have a picture that looks like this. And remember, it's pretty much non-infectious etiologies. Because if it was infection, it would just be called pneumonia, and it wouldn't be called ARDS, even though infection is included in the differential diagnosis. Now, if I took a pediatric pathologist and I told him that this was a premature baby that was born without much surfactant because they were born very prematurely, he would say, "Oh my God, you don't just have water leaking out into those alveoli. We have actually damage to these alveolar walls, or alveolar septae, so to speak. This red stuff is fibrin. This fibrin is often described as hyaline membranes. We have cells. We have desquamation of the lining cells. We have hemorrhage. So this is a picture of ARDS. And you could fool a pediatric pathologist and tell them this was from a baby. In other words, neonatal RDS. But this happens to be an adult. The coincidence is that they're both look the same. And in the baby, these little fibrinous membranes that are collecting in the alveoli, like here and here and here, they are hyaline, or they're red. So in babies, this might be called, rather than neonatal RDS, this might be called by the little bit of an older name called hyaline membrane disease. Okay, so once again, I had a professor in medical school that did a lot of work on this. He preferred to call it shock lung. Why? Because when you have DIC due in shock, which we went over like thoroughly, you have damage, to those small thrombi in those alveolar capillaries, and that would be a cause for the damage and the leakage of protein and fibrin and cells into the alveolar spaces, rather than just water like you see with pulmonary edema. Okay, I'm going to mention this briefly. There's another type of pneumonia, which is a non-infectious pneumonia. And it could be called acute interstitial pneumonia. And you could think of it pretty much as ARDS, because it looks very, very similar, but it has no known etiology. Okay, if it was caused by a bacteria, they wouldn't be calling it acute interstitial pneumonia. They'd just be calling it pneumonia. Okay, but here, let me show you something. Why would it be called interstitial pneumonia? Because the primary area of inflammation is in the alveolar septae, or the alveolar walls, rather than the alveolus itself. And that's why it's called interstitial. Okay. We covered the acute pulmonary injury patterns. We covered the atelectasis concept. We covered the congenital pulmonary diseases. So I think it's about time we dived into our biggest topic and concepts of obstructive lung disease versus restrictive. Okay, let's talk about the concepts in general before we rattle off the various diseases, okay? In an obstructive lung disease, you're thinking, well, you told us that the lung is nothing but air holes and blood holes. So what's obstructed, the air holes or the blood holes? Well, it's the air holes, okay? Okay, well, now that you told us it's the air holes, is it obstructed on inspiration or expiration? Well, it's obstructed on expiration. Okay, good. Is it the large air holes or the small air holes? And the answer is, it's the small ones. It's the bronchioles, okay? So, when you talk about obstructive lung disease, we're talking about a problem with expiration, because the small air holes, the bronchi, the respiratory bronchiole, even some of the larger bronchioles are obstructed. and they're usually obstructed because of allergic and or inflammatory diseases. So let's review it because it's important. Obstruction is small airway, primarily expiratory obstruction, and that's what causes the wheezing, because you cannot get out all of your air from the alveoli because the bronchioles before the alveoli, or now with expiration, are after the alveoli, are obstructed. And because they are chronically obstructed, these causes an increased pressure in the alveoli, and they are chronically not only hyperexpanded, but they could actually be ruptured between their neighbors' walls, and they would produce what you would call a hyperlucency, or a loss of normal density on chest x-ray. That's the concept of obstruction. Okay? It's small airway obstruction resulting in chronic hyperexpansion, chronic rupture of the alveoli. And remember, this is going to be more noticeable in the peripheral portions of lungs, where most of the alveoli are and most of the small airways are. And it has a classical appearance on chest x-ray. Okay, now take 2 or 3 deep breaths, because that is one of the primary pathophysiologic categories of non-pneumonia pulmonary diseases. However, chronically obstructive lungs also can have a big, highly increased risk of regular old bacterial pneumonias. Viral too, but mostly bacterial. Okay. Now, what is the concept of a restrictive lung disease as opposed to an obstructed lung disease? In restriction, probably the key word is compliance. You know, we talked about ventricular compliance when we talked about heart diseases. But now we're talking about pulmonary compliance. What is a compliant organ? What is a compliant tissue? A compliant tissue is tissue that moves like it should be moving, okay? Whether you press on it or whether it's moving in real life, okay? So a loss of compliance would be if you technically at autopsy squeeze the lungs and they didn't squeeze like they should, perhaps because the alveoli, rather than being filled with air, were filled with either water or perhaps tumor or some type of cellular infiltrate. So therefore, in restrictive lung disease, you have a reduced lung volume. In restrictive lung disease, you may have dyspnea, increased breathing to make up for the reduced lung volume, or cyanosis, because there's perhaps a large portion of the lung that's just not working, so the blood is not getting properly oxygenated. But what is the other key feature now? Because we talked about cyanosis, we talked about reduced lung volume. It's reduced gas transfer. So if the function of the lung is to gas transfer, when you have a lung that is not moving like it should because it's infiltrated with either fluid or that, you're going to have ultimately in your pulmonary function lab the concept of reduced gas transfer. And this is usually a diffuse phenomenon. So when a radiologist looks at physiologically some type of lung with a restrictive lung disease, if there is an increase in substances, water, protein, whatever, filling up those alveoli, it may not be lucent, okay, on chest x-ray. He might describe it as a ground glass appearance. In other words, it's not as clear or it's not as lucent as it should be. Or he might even call it a mild diffuse infiltrate, which also means, loss of lucency. Okay, I hope, every year when I explain these two concepts, I hope that I can explain them clearly. Now, you probably have already thought, are all lung diseases either obstructive or restrictive? The answer is no. In many, perhaps even most of them, you may have elements of both. So when you do your pulmonary function tests, which measures the degree of obstruction, no matter what the disease is, or the degree of restriction, no matter what the disease is, you may have elements of both in many, if not most, of the major common significant pulmonary diseases. Okay, now that we hopefully explained clearly the obstruction versus restriction concepts, you know what? Let's talk about the obstructive ones, and then we'll take our break because these are both pretty big topics. Let's talk about the concept of an obstructive lung disease. And remember, another common name for a chronically obstructive pathophysiologically lung disease is emphysema. And also, because these are generally chronic and worsening with life, very often obstructive lung disease or obstructive pulmonary disease is almost never called OPD. It's usually called COPD. So, are you thinking, could COPD be perhaps a pretty good definition to describe emphysema? And the answer is yes. So for all practical purposes, COPD is emphysema. It's basically an end-stage type of lung disease. It may be preceded by chronic bronchitis. Because what happens if a chronic bronchitis or bronchiolitis results in chronic expiratory small airway disease with overexpansion of the lungs, resulting in alveolar overexpansion and the loss of the space or the wall or the septum between the alveoli? Okay, you have chronic bronchitis if worsening or persistent, leading into emphysema. Almost all emphysema is preceded by chronic bronchitis. What if that chronic bronchitis or bronchiolitis is caused by an allergic type phenomenon? Then you could call it asthma. Okay. Now, a fourth type of chronic obstructive pulmonary disease, which is on this list, but it doesn't quite fit the picture as easily as these three, is bronchiectasis, which is basically destruction of the integrity and therefore dilatation of the larger bronchi. But these are all situations which pathophysiologically would result in the inability to exhale quickly after an initial deep inspiration. Perhaps you've been to some of these science fairs or medical health fairs where there's a guy standing there with a hose and he tells you to exhale into this tube as quickly as you can. Well, the worse that your obstructive COPD is, the longer it's going to take you to exhale. Should I say that again? The worse your COPD is, the longer it's going to take you to force a expiratory volume. That's why they call this the FEV test. And if they measure it after a certain amount of seconds, like 1, they may call it a FEV1, is basically abnormal with the obstructive lung diseases. Now, emphysema itself, we said it's basically preceded by chronic bronchitis. You can also think of it as an end-stage lung disease, okay? And it could involve the portion of the lung that is called the central portion of the acinus, which is a larger unit of function, or the entire acinus, which would be a pan-acinar emphysema, or something that's along the septum irregularly. These are different types of classifications of emphysema anatomically or histologically, and different types of emphysema might correspond to different diseases, but for the most part, you'll almost never hear somebody saying, oh yeah, I have pan-acinar emphysema, but I'll show you the difference anyway. Now, like cirrhosis, which is the end stage of multiple injuries, you can think of emphysema as end-stage lung disease also. It doesn't reverse. It doesn't get better. There are various palliative things that you could done, bronchodilators and antibiotics if there's secondary infection, but it is not a specific disease. It's non-specific, and it could follow a multiple long list of etiologies. So, wouldn't you guess that if a alveoli are filled with fluid, it would be decreased crepitance or decreased bubbliness when you squeeze it? But in emphysema, because the alveoli are overexpanded and perhaps ruptured, it results in increased crepitance. And also, if there's less lung tissue, because the alveoli are overexpanded, rather than having an infiltrate in the lung on x-ray, it might be actually the opposite, and you would have increased lucency rather than an infiltrate. And people with emphysema, no matter what caused it, are at risk for recurrent pneumonias, usually bacterial pneumonias, and there's a couple that are a lot more common than the others, but basically emphysema patients often go to the hospital to be treated for pneumonia as well. Here's a lung, and if you've seen a lot of lungs, you would say, wow, you know, this looks like it's a lot spongier than it should be. Why? Because the air spaces are overexpanded, that's why. So in the centroacinar type, technically speaking, I'll make this a little bit of a bigger picture. You have, if this is an acinus in the lung, everything following the respiratory bronchi, it's basically the central portion that is the worst. In technically speaking, in a pan-acinar, it's the entire acinus, or everything after the respiratory bronchus that's overexpanded. So, let me ask you a question, and I think it's a no-brainer. What would happen? What do you think is worse? A pan-acinar, you know, the entire acinus, or just technically a centroacinar, which is just the central portion of the acinus? Of course, the pan-acinus would be technically, everything else being equal, a pan-acinar would be worse. Here is your lung, emphysema lung at autopsy. Okay, what are these big blebs at the periphery of the lung, especially higher towards the apex? These are called bullae. And believe it or not, at one time, that grape-sized thing was a single possible overexpanded alveolus. But in the process of chronic hyperexpansion and rupture between adjacent alveoli, it formed these bullae. And radiologically speaking, if this is a bullae in the lung and there's no lung tissue within this little air sac, you're not going to see vascular spaces either. So these can be described on chest x-ray or CT very easily as well. Here's the actual lung that's now fixed, and you could see, you know, if you've seen even one or two lungs, you know that this sponge has bigger and more holes than it should be. And they're usually more prominent at the periphery of the lung, okay, where there is less bronchial and cartilaginous tissue, so to speak. What are the classical four findings then? We've mentioned them already. Not only are their lungs hyperexpanded because of the problem with expiration, but they're chronically hyperexpanded. So the diaphragm may actually be kind of what they call flattened or blunted. So rather than being a nice curve, it may almost look like a line. So the radiologist may say, the lung fields are hyperexpanded. Maybe they extend down to more ribs than they should be. The diaphragms are flattened. Okay, that's because of the overexpanded lung. Now he may see a bullae. Now I know what you're thinking. You're thinking, how could you tell this is a bullae? Well, if it was a normal lung tissue, you would, even if it's generally lucent, you could see, a radiologist can see generally little tiny linear things representing blood vessels or bronchi, okay? But if there's absolutely no blood vessels or bronchi in a lucent area, then you can say it's probably just a big air sac, which is, of course, a bullae or a bleb. And in general, the lung fields are increased in lucency in general. And that might also be described by the pathologist as increased crepitance because of increased many bigger holes. In other words, increased bubbliness, increased sponginess when you squeeze it. Okay? Chronic bronchitis. If you have ever taken a breath after you were born, during your entire life on planet Earth, even if you don't live near a big city or you're not a coal miner, or maybe you live on the farm, and if you've been chronically exposed in the air to various pollutants or inhalants, cigarette smoking, almost every single emphysema patient that you'll get probably was a smoker, and often for many years. Chronic bronchitis leads to asthma, and I think now you understand how and why. Because of the chronic irritation to the bronchi, you'll have mucus hypersecretion. In other words, more goblet cells than you normally see lining the bronchi and bronchioles. And secondary to that, of course, bronchitis means inflammation, so a chronic bronchial inflammatory infiltrate means you'll probably be seeing more, lymphocytes and macrophages surrounding these bronchi. Now, chronic bronchitis is something that almost every one of us, whether you're a smoker or not, or whether you live in Pittsburgh or not, whether you lived in an industrial city or not, probably we're at risk for, okay? If you smoke or you have an occupation what aggravates it, then it's even much more of a risk. Asthma. You could think of asthma as chronic bronchitis, but rather than the air that you inhale being filled with irritants, you have an allergic reaction, okay? So asthma has a strong role in allergy, in which you might see eosinophils as your inflammatory infiltrate, IgE as your primary immunoglobulin, and a whole list of allergens or things you might be exposed to, people say, cat hair or whatever you could be exposed to and has contact with the air of the lungs could be a cause of asthma. And this is a disease which is generally lifelong, usually starts in childhood. Now, you could say it could be divided into two types of asthma. Something they called atopic, which is allergic, which is the common type of allergic asthma. But could you have an asthma that is not allergic? That's called non-atopic. Now I know what you're thinking. You're thinking, is non-atopic asthma probably very, very, very intimately related, if not identical, to chronic bronchitis? And the answer is yes. So if somebody, in all honesty, was to ask me, what's the difference between non-atopic asthma and chronic bronchitis, I'd probably scratch my head for 10 minutes and say, I don't know. But because asthma has a chronic bronchitis with a strong allergic counterpart, when you look at it microscopically, you're going to see inflammation. If it was more allergic, you'll see more eosinophils. If it was non-atopic, you're most likely to see primarily lymphocytes and macrophages because it's chronic inflammatory insult. Because of the response, you're going to see mucus hypersecretion, maybe even mucus plugging. So that might be one reason for narrowing the lumen, is that there's a big glob of mucus in it. And sometimes when you cough, that's what causes the sounds that you hear, okay, on its expiration. And is also be one of the reasons for narrowing of the lumen. Another reason is simply because there's a lot of inflammatory cells narrowing the lumen. Another reason for having bronchospasm or wheezing is the fact that in response to all this, the smooth muscle hypertrophies as well. I'm going to show you a little picture, and then I'm going to show you a big picture. Here's a little picture. Here's lung. You could instantly recognize that. Here's a small bronchi. It's not a bronchiole because technically you have a little piece of cartilage in there. You have a lot of inflammatory cells and even lymphoid follicles surrounding these bronchi. You can see it's loaded with mucus, which is this gray stuff. And you might also believe me when I tell you that these smooth muscle fibers are thicker than they should be. And if you don't believe me, I'm going to show you a bigger picture. Look, 4 is your increase in smooth muscle cells surrounding your bronchus or bronchiole. Okay. 3, all of this gray stuff is mucus secretion. So you should normally have a certain number of goblet cells in your bronchi, but perhaps in asthma you have way more than you should. That could narrow the lumen as well. Here are your inflammatory cells. Up here they look like they're primary lymphocytes, but if it was an atopic asthma, you might have a lot of eosinophils too, because eosinophils are indicative of an allergic response, which we learned way back when. The fourth and last type of obstructive or chronic obstructive pulmonary disease is not a disease in itself. It's a concept, like atelectasis. And this is called bronchiectasis. And whereas we said atelectasis was collapse of the lung, bronchiectasis is dilatation of the larger bronchi. Okay? Now, if this larger bronchus has been subject to an inflammatory or infectious etiology like TB, or a whole wide variety of other bacteria, a lot of viruses, you're going to have technically disease at the larger bronchial level, not the smaller ones like you had with asthma and chronic bronchitis, okay? You should also know that bronchiectasis could be a congenital anomaly as well. I don't know if we mentioned it at the beginning. Now, what would be some of the processes that might dilate the bronchi and weaken its wall? Well, besides these inflammatory, infectious etiologies, you could have your so-called systemic autoimmune diseases like lupus, like rheumatoid arthritis, and even inflammatory bowel disease, which is generally regarded as autoimmune as well. Okay, inflammatory bowel disease like Crohn's disease or ulcerative colitis. These are all things that could result in bronchi that look like this. I know what you're thinking. You're thinking, what's that big hole? It looks like it's really should be too big for this part of the lung. Well, it's a bronchus that is dilated, but also in many respects narrowed because the wall is inflamed. Look, here's one, here's one, here's one, here's one. This is bronchiectasis. Okay, these are not bullae because bullae are at the periphery of the lung and they're basically just covered with a thin layer of pleura, but these are actually large, dilated, inflamed edematous bronchi. Okay, you know what? We talked about the whole family of obstructive lung diseases. So let's take our break. I think we did a pretty good job, and I think we explained the concepts of the obstructive lung disease. When we come back, we'll go into the family of the restrictive or infiltrated pulmonary diseases, in which loss of compliance is the main feature. So we'll give you a couple of Journey and maybe a song by Phil Collins, and then we'll come back in about 10 minutes. The one thing that I remembered during the break, I always remember something during the break that I should have said. I told you that Journey and Genesis were going to be our two singing groups, but you know I forgot to mention Mark Anthony singing his awesome signature song, Vivir Mi Vida. So those were the three guys that we heard. And I think probably at the very end we'll hear another Genesis song as well. So we've done a lot of discussion today about the non-pneumonia, the non-neoplastic pulmonary diseases. But there's still a little bit more to go. And basically one pretty good sized discussion now on the so-called restrictive lung diseases. So let's see if we could get with it. Okay. Whoops. How about if we close this? Whoops. There we go. Get back with our PowerPoint here. The concept of a restrictive lung disease. We describe them as being infiltrative. We describe them as often the radiologist talking about a ground glass appearance because the infiltration produces less than a normal amount of lucency, or let's say an increased amount of radiodensity. But we also said that one of the key functions or dysfunctions on your pulmonary function test will be reduced gas transfer. And these are the common features of the restrictive pulmonary diseases. But the restrictive pulmonary diseases may often have obstructive phenomenon as well as vice versa. So this is going to be our big topic. Then we'll say a relatively few words about the vascular pulmonary diseases. I guess if you wanted to categorize or sort the restrictive or infiltrative lung diseases into groups, remembering that the primary pathophysiologic concept is a reduced compliance, reduced gas exchange. They're generally diffuse, and they have a whole bunch of etiologies, and I'm going to go over 5 or 6 of the common ones, some of which are idiopathic, of course. So any disease which causes a diffuse fibrosis of the lung, including ones which are idiopathic, and we don't know why, would have the adjective of a fibrosing restrictive lung disease. A diffuse granulomatous type of disease, like a pneumonia, would also result in reduced compliance, reduced air transfer, not only loss of lucency, but perhaps tiny pinpoint areas of density, which are the actual granulomas. Another category would be the eosinophilic lung diseases, okay, may or may not be related to specific discoverable antigens. Another big category, which is smoking related, and primarily more in men than in women, even in younger men, as one of the categories causing diffuse infiltrative restrictive functional changes. And another mysterious disease called PAP, pulmonary alveolar proteinosis. In other words, if you remember when we talked about pulmonary edema, we said that pulmonary edema is like a normal lung with the water in the alveoli. With PAP, it's a relatively non-inflamed lung with a lot of proteinaceous material inside the alveoli. That's why it's called PAP, okay? Pulmonary alveolar proteinosis. The fibrosing lung diseases, well, one of the easy ones would be called idiopathic, because it's no use discussing about what causes it. We don't know. That's why it's called idiopathic. They often abbreviate it as IPF, which, by the way, a lot of these lung diseases are going to get 3-letter acronyms. Another one related to it, but a little bit more inflammation than just fibrosis, is so-called nonspecific, kind of a wastebasket diagnosis. But basically anything that causes a lot of fibrosis and inflammation in the lung, and probably a specific infectious pathogen cannot be found, might be called nonspecific interstitial fibrosis. Remember, all of these restrictive lung disease primarily are non-classical pneumonias. Something called COP, a nice name, cryptogenic organizing pneumonia, which we're going to see, talk about a little bit as well. And remember, the so-called systemic autoimmune diseases, like lupus and rheumatoid and scleroderma, they were in the past generally referred to as the collagen diseases. We don't like to call them collagen diseases anymore, because we have a whole family of diseases now that we know are subject to various types of abnormal forms of collagen. Nevertheless, the reason why the systemic autoimmune diseases were called collagen is because it was systemic inflammation of unknown etiology, therefore autoimmune. And inflammation, the chronic inflammation primarily, often resulted in fibrosis, and that includes the lungs. Pneumoconiosis, that might be a big word, but basically all that means is the wide, big family of occupational lung diseases, of which perhaps coal miners might be at the top of the list, but there's a whole bunch of them I'm going to show you. The drug reactions can cause inflammation and fibrosis in the lung, certain drugs, okay, as well as radiation. Of course, radiation causes fibrosis. Radiation causes inflammation. Inflammation is followed by fibrosis. So this is the general family of the so-called fibrosing restrictive lung disease. Here's the first one, idiopathic, okay? Look, you have a lung here, and what is all this pink tissue? Well, if you did a trichrome stain, it'd probably be blue. This is all collagen. This is all fibrosis of the lung, to the point where there's hardly any air spaces left, to the point where it would be called a loss of crepitance, to the point of where it would be called perhaps ground glass or increased density by a radiologist. And of course, the I stands for idiopathic, which means we don't know what caused it. If this patient had lupus, if this patient had scleroderma, if this patient had rheumatoid arthritis, then it wouldn't be called idiopathic, because we know the reason. But the main feature is fibrosis. And if you are sick of 3-letter acronyms, sometimes idiopathic pulmonary fibrosis is called UIP, for usual interstitial pneumonia. But let's forget about that. Here is something very much related to it, and of course, it's also mysterious. It's also idiopathic. And basically, I said it was a wastebasket diagnosis. If you have a patient that presents with pulmonary fibrosis, as well as inflammation, by chronic inflammation, which means basically lymphocytes, macrophages, plasma cells, and it's still truly idiopathic, which means an unknown etiology. Sometimes that lung is diagnosed as non-specific interstitial pneumonia. It's non-specific because we don't know what the specific cause is, okay? COP, cryptogenic organizing pneumonia. To tell you the truth, I do not know why it's called cryptogenic. I'm sure there's a good reason. But in cryptogenic organizing pneumonia, or COP, you see basically organizing inflammation. Okay, in other words, increased blood cells, fibrosis. Probably a better name for it, and often it probably is used, as the term bronchiolitis obliterans. Okay, now that means that these bronchioles here, you can see this is a bronchiole because it has a nice epithelial lining. It's obliterated by fibrous tissue or organizing tissue as well. And even though it is still in this a mysterious disease, in other words, idiopathic, you often see patients that have had lung transplants, develop this. And that would be logical, because if you have a lung transplant, you have every reason to have some immune reaction against it. And if that follows inflammation and organization and fibrosis, you might see why a lot of these bronchioles are obstructed. That would be a reasonable hypothesis. Now remember, once again, this is the family, the common family. There's 3, but we could probably add a couple more, like polyarteritis nodosa. But these are the so-called collagen vascular diseases. When we talked about them before, we called them systemic autoimmune diseases. In other words, they are reacting against antigens in your own body. Rheumatoid arthritis, you're reacting to part of an antibody. In lupus, you're reacting against DNA, RNA, the proteins which surround it, and also with progressive systemic sclerosis. Because it is progressive, it is systemic. And it used to be called scleroderma, but now it's called PSS. Why? Because it's not just the skin that's fibrotic. It's many, if not most, of the internal tissues as well, of which lung is one of the number one things. So, a chronic autoimmune inflammatory reaction involving the lungs ultimately will produce fibrosis, collagen deposition, and that's why they were called collagen diseases. Otherwise, if this patient did not have a known autoimmune disease, it might just be called idiopathic pulmonary fibrosis or nonspecific, okay? But now we know that it is secondary to these specific diseases. Pneumoconioses are the occupational lung diseases. You know that if somebody's a coal miner and they're breathing that coal dust their whole life, they're likely to get fibrotic changes in their lungs. Other types of dusts or chemicals, organic materials. Here, I included 4 of the common ones. For example, coal, which would be anthracotic pigment. The lungs are black because the anthracotic pigment is loaded in the macrophages of the lung, particularly the part of the macrophages which are the most numerous, which are in the lymphatics. And the lymphatics are most numerous, subpleural. So that's why these lungs look black. And if you cut them open, they might be less black on the inside. Silica, dust, okay, silicon, asbestos. Asbestos is not only something that has been highly indicted with mesotheliomas, or tumors of the mesothelial lining the pleural and peritoneal and pericardial surfaces, but also fibrotic changes in the lung. I get some compounds that are also indicted. People that work with barium sulfate, iron oxide, beryllium, these deposits in the lung, as well as certain chemotherapies. Okay, I'm not going to list the most common ones, but probably there is, if there is a warning label or a package insert on the particular chemotherapy, it may very well, mention, pulmonary damage, pulmonary fibrosis. Hay, flax, something called bagasse, which I bet you'd never heard of, insecticides. These are common industrial or even farm-related toxins, which people can get chronic fibrotic lung diseases from. I'm going to show you pictures of some of them. Well, you know that's coal, okay? And if you didn't know what bagasse was, this is bagasse. If you've ever been to a part of the world that grows sugar cane, this is kind of like the remnants from it, these little vegetable type fibers. Here's silica. And when you see silica now, you may have granulomas that look like they're kind of amorphous or acellular, just kind of a blob, surrounding lung tissue. These are silica granulomas. And here's another interesting concept. What are these little brownish rods inside of the lung here? Say, well, they look like they're colored like iron. Could that be iron? Well, I got news for you. You might think they're iron, and you might think they're iron because they're called ferruginous bodies, but they're actually various crystals of asbestos. These are all basically things which can damage the lung, resulting in a diffuse or perhaps restrictive type of lung disease functionally, often with a lot of fibrosis as well. Do we have anything else on the list? Oh yeah, we have the granulomatous lung diseases as well. Sarcoid being at the top of the list. Now, the deep systemic fungi also cause granulomatous changes in the lungs, but they are not listed with the this type of granulomatous disease. In sarcoid, you could get granulomas in the lung, but granulomas everywhere. It's a lot like tuberculosis, but the granulomas from sarcoid are characteristically described as non-caseating. And the more we study sarcoid and the more we cannot attribute it to a specific etiology, the more we're likely to call it idiopathic or even autoimmune, okay? The granulomatous diseases you see with certain dusts and bacteria and fungi. Farmer's lung disease is a specific syndrome in which there's hypersensitivity resulting in granulomas, as well as people that breed pigeons. So you could Google farmer's lung disease if you want to read something interesting, or pigeon breeder's lung disease. These are basically granulomatous diseases, besides sarcoid, which is idiopathic. And of course, the hypersensitivity ones are not idiopathic. They're secondary to dust, bacteria, or whatnot. But we've got to say a word about sarcoid, okay? Sarcoid is granulomatous disease like tuberculosis. It's primarily in the lungs like tuberculosis, but it can occur anywhere. We can see it in the brain, we can see it in the skin, okay? There probably hasn't been a single place in the body where sarcoid has not been described. It is truly unknown, so we could call it idiopathic. I noticed that some people are starting to call it autoimmune because it's a type of inflammatory reaction, granulomatous inflammatory reaction, with no known specific pathogenic organism causing it, like tuberculosis. It has genetic factors, and of course it's more likely in a closer degree relatives. It's significantly more common in women than men, and it's significantly more common in black women than in white women. So basically, if you do get a sarcoidosis patient thrown at you on some type of licensing exam, that almost certainly is going to be a young adult black woman with granulomatous changes in her lungs. This is what the granuloma might look like of any granulomatous disease, with basically the macrophages occupying the center and the lymphocytes being more at the periphery. And of course, in sarcoid itself, this happens to be a mesenteric lymph node, so it's not lung. In sarcoid itself, the granulomas do not become necrotic or caseate. So the classical definition of a granuloma of sarcoid is non-caseating granulomas. And here's a funny little thing. Does this little red thing look like a star? Well, it happens to be something you can sometimes, but not always, see in sarcoid called an asteroid body because it looks like a star. However, once I Googled the differential diagnosis of asteroid body, and it was found in a few other things, but the most common place you'll find an asteroid body in the middle of a granuloma is probably sarcoid, okay? And I've seen a couple of them, but whenever I saw a case of sarcoid, I was always look hard and long for them. Here is a regular non-caseating granuloma on the right. It has chiefly, all these cells are macrophages. Some of the macrophages fuse their cytoplasm under the influence of certain cytokines to become multinucleated giant cells. The lymphocytes are generally more at the periphery of the cluster of macrophages. But look, everywhere within this granuloma, you see cells that have nuclei. In this granuloma, you can see some lymphocytic clusters at the edge. You can see even some lung tissue. You can see that these are primarily macrophages. You could even see some giant cells like here and here and here. But look, most of the cells in this cluster or in this granuloma do not have nuclei. Why is that? It's because they're necrotic. It's because if you cut it, it would crumble because it's necrotic. It would cut like cheese, and that's why they're called non-caseating. Okay, I'm sorry, that's why they're called caseating, because you may know that queso is the Spanish word for cheese. Okay, what do we have here now? Here's another type of restrictive lung disease. And remember, we said very often the alveoli are filled with things. It might give a ground glass appearance. It's diffuse. So what are these cells inside of the alveolus there? They're macrophages, okay? These are alveolar macrophages. Remember, the macrophages kind of patrol the septum of the alveoli, but if there's some type of irritant, like cigarettes, they can become more numerous, and in here they happen to fill up or desquamate. In other words, they peel off from the septum and they fill up the alveoli. That's why it's often called a desquamative interstitial pneumonia. And in keeping with our three-letter acronyms, it's also called DIP. It's 100% smoking related. It's much more common in men. And the removal of cigarettes basically results in a 100% survival. Do you remember when we talked about that vascular disease called thromboangiitis obliterans, in which the arteries were obliterated, also caused by cigarette smoke? This is similar because it's more likely in men than in women, and their main therapy is the removal of cigarettes from that man's life. The last type of general restrictive lung disease, which you might say is infiltrated, is when the alveoli are infiltrated by proteinaceous material. It's a very rare disease. I never saw one myself, okay? But take a look. Here on the left, we have a lung, and this is the same picture I showed you, where there is very little lung inflammation, but the alveoli are filled with water, which is light. In PAP, or pulmonary alveolar proteinosis, it's very similar. There's very little inflammatory changes in these alveoli, but some proteinaceous material has leaked out into the alveoli. So would you say it would be fair histologically to say that if pulmonary edema was water rather than air in the alveoli, then PAP was proteinaceous material rather than air in the alveoli? Okay, and it's usually an acquired disease. And I've noticed from one of the textbooks I was reading, they say it's usually acquired. So I guess it could, either be a genic or multigenic, but there's never been a single gene which has been indicted, in this disease. Okay, we're basically done with the biggest part of our discussion here, but I want to say a few words about the so-called pulmonary vascular diseases, okay? Now remember we said that some of the congenital lung diseases could result in abnormal development of blood vessels, including and especially pulmonary arteries. Well, this is separate from this. This is going to be the general category of lung diseases resulting from abnormal pulmonary vessels. Pulmonary embolism at the top of the list, still a big, perhaps number one killer of debilitated people who develop deep calf or deep pelvic blood clots. Pulmonary hypertension is entirely or primarily related to narrowing of the small pulmonary vessels, resulting in increased resistance and therefore pulmonary hypertension. This vessel narrowing is not only be a cause of the pulmonary hypertension, but it could be an effect, because the more pressure you put on these small vessels, the more likely you are to damage them. And then there's a couple of so-called hemorrhagic lung syndromes, of which Goodpasture disease is a hemorrhagic lung syndrome, patient presenting with hemoptysis, but it's also related to renal failure as well. So let's say you had an autoimmune disease in which you're making antibodies not only against the basement membrane of your lung, but the basement membrane of your kidney. Well, that was basically the problem with Goodpasture. And do you also remember when we talked about chronic congestive heart failure? We said that blood can ultimately leak out into the alveoli, and the blood hemoglobin can then evolve or chemically change ultimately to the storage form of iron or hemosiderin, and you could have a lot of hemosiderin in the lungs just from chronic congestive heart failure. The macrophages eat up them, and they're actually in the macrophages in your sputum. We talked about heart failure cells. Well, there's a type of pulmonary hemosiderosis other than chronic congestive heart failure, which is called idiopathic. And that usually results in even much greater amounts of hemosiderin or chronic blood pigments being deposited in the alveoli in the lungs. And do you also remember when we talked about vascular diseases, we said a type of vasculitis involving both the lower as well as the upper respiratory tract was a disease, sometimes serious, called an autoimmune disease called Wegener's granulomatosis. Well, technically, that could be a vascular pulmonary disease as well. So here's a PE. What are the features of a general pulmonary embolism? Well, if you're lying in bed due to any significant chronic, long-standing, serious illness, you're not walking, you're not exercising those valves in your legs, and the deep veins tend to stagnate with fluid, and that's one of the angles of Virchow's triangle, which is flow problems or stasis, resulting in endothelial disruption and coagulation, therefore blood clots. Most of the significant pulmonary emboli come from the deep veins of the leg and the deep veins of the pelvis. You can have a blood clot in superficial veins, and generally they do not result in significant pulmonary emboli, okay? Now, when an embolism, blood clot, then travels up to the lung, even if it completely obliterates part of it or an entire pulmonary artery, usually it does not infarct. Usually the lungs still ventilate even though they don't perfuse. So that's called a VQ mismatch. In other words, they ventilate V, but they do not perfuse. Sometimes, especially when there's compromise of the bronchial circulation as well, like the patient may be in congestive heart failure, okay, they actually also do not ventilate because they are infarcted. And of course, an infarct of an organ that has a dual blood supply is usually hemorrhagic. And in the lung, the infarcts are the most present and the most obvious at the peripheral pleural surfaces of the lungs. So I've seen pathologists, I mean really good pathologists, you know, guys that I want to be like someday. I could see them doing an autopsy and closing their eyes when they remove the lungs just to feel for hemorrhagic infiltrates at the periphery of the lung pleural surfaces. Now, if they don't ventilate, they might have an infiltrate because it's hemorrhagic. So most of the time, the chest x-ray is normal, and because they're ventilating normally. But if they're not perfusing, you know, they may actually show up as a significant segmental or subsegmental or even an entire a lobar defect on a perfusion scan. They would show up as a defect on the angiogram. And if there was an actual blood clot in the pulmonary artery, these can be even detected by CT. So, you know, they're basically treated with short-term heparin and long-term Coumadin. First, they go to the intravenous anticoagulates, and then when they're released, they may be on Coumadin for years. But remember one thing about PEs, and I know you're not going to believe it, but I'm going to tell you anyway. Most of the pulmonary emboli are asymptomatic. How do you like that? Okay, so here's a perfusion lung scan, and you can see it looks like that's probably part of the right middle lobe, either a segment or the whole thing that doesn't perfuse. But look, it ventilates normally. So when you give a radioactive gas, it passes in and out. Why? Because it's ventilating. Even the part of the lung that is not perfusing is ventilating. So that's what they call the VQ mismatch. Okay? Here is an autopsy of a person that died, obviously, of a fatal pulmonary embolism. And to me, it looks like it's actually branching. It looks like it's over the bifurcation of the main pulmonary artery, which means it was fatal instantly, okay? Because if you block more than 60% of the pulmonary outflow tract suddenly, it's usually fatal. And of a saddle embolism, which blocks both pulmonary arteries, is most likely going to be blocking well more than 60% of the lung. Here's a CT scan. And I'm not this good of a radiologist, but he might tell you that that's the actual blood clot there. But remember, folks, if the patient is not infarcting, which they don't do most of the time, most of the PEs do not result in an infiltrative hemorrhagic infarct, okay? So most of the PEs do not show up as a chest x-ray infiltrate. How do you like that? I think we're down to our last, pulmonary hypertension. We talked about right heart failure due to sustained pulmonary hypertension, or something we called about cor pulmonale before. But now we're going to talk about pulmonary hypertension in itself without it affects of a heart or right ventricle. Patients with COPD have narrowing, generally, of the small arterioles of the lung. Even patients with interstitial lung disease, okay, have narrowing of the vessels in the lung. So patients with chronic lung diseases of various types have narrowing of the small blood vessels of the lung. Now, if you narrow the small blood vessels of the lung, you're going to put an increased strain on the right heart and the right ventricle. You can also have a pulmonary hypertension if there's been some type of congenital heart disease that involved increased left atrial pressure. So if you have increased left atrial pressure, you're going to have increased pulmonary vascular pressure, and therefore perhaps right ventricular hypertrophy, even failure of the heart, primarily due to the extreme right ventricular strain. People that have recurrent pulmonary emboli have another reason for narrowing of their pulmonary vessels, don't they? And last but not least, remember patients with these systemic autoimmune diseases like lupus, like scleroderma, like rheumatoid arthritis, they can have fibrotic vessels and therefore pulmonary hypertension. So what do these four things all have in common? What they have in common is that if there is some type of narrowing of the pulmonary vasculature, particularly the small vessels, you're going to obviously have pulmonary hypertension. Here's a normal pulmonary arteriole. There's blood in it. There's some nice little alveoli and alveolar septae at the edge, capillaries inside the septae, but a nice, beautiful looking arteriole. But look, this one is thickened. And think about it. If the lumen of this pulmonary arteriole is narrowed because of some inflammatory or fibrotic change, you're going to have pulmonary hypertension, aren't you? Okay? Now listen to this. Not only is this narrowing causing the pulmonary hypertension, but now increased pressure in the right ventricle can complicate it even more, because increased pressure in a blood vessel can also damage its endothelium and its wall. Hemorrhagic syndromes, last topic. Goodpasture disease or Goodpasture syndrome is an autoimmune disease in which patients make antibodies against a part of their collagen protein called the alpha-3 chains of collagen type 4. Now, what is collagen type 4? That's the collagen of the basement membrane, isn't it? Remember we said collagen 4 is on the floor. So collagen 4 is the type of collagen. There's about 13 different kinds, but 4 is the one for classical basement membrane. And if you have antibodies against your basement membrane of the lung, you're going to have damage, okay? And guess what? That's the same type of basement membrane collagen that's in your glomerular basement membrane as well. So a Goodpasture syndrome classically presents with hemoptysis and renal failure. I guarantee you, if you ever have a test question about Goodpasture in one of these clinical scenarios, they're going to say patient comes in with hemorrhage and hemoptysis and renal failure. Well, instantly you think of Goodpasture. But if you look at some of the other symptoms, dyspnea, obviously because of the lung disease and cough, fatigue, which is common to just about everything, hematuria because of the glomerular basement membrane damage. Idiopathic pulmonary hemosiderosis, okay, may look like severe chronic congestive heart failure because of all the hemosiderin due to blood breakdown in the alveoli. And the last type of hemorrhagic syndrome is a vascular disease, an autoimmune vascular disease, in which you have autoantibodies against your neutrophilic cytoplasm. So the ANCA, ANCA antibodies are present usually with Wegener's. These would all result in hemorrhagic lung syndromes. Now let me show you something as our last picture, just for a comparison. This is a patient with chronic congestive heart failure. Okay, there's increased pressure in the lung vasculature. Okay, it results in leakage of not only fluid, but some blood into the alveoli. The blood breaks down, becomes hemosiderin, and there's a stain called a Prussian blue stain, which can really stain hemosiderin very well. So that's what you might see with chronic congestive heart failure. These cells can also be in the sputum, and they're called heart failure cells. Isn't that convenient, okay? Isn't that appropriate? But in idiopathic pulmonary hemosiderosis, I am told that the amount of hemosiderin in these alveoli is generally a lot worse than in chronic congestive heart failure. Hey folks, we're done. Thanks for staying with me. I appreciated some of your comments. I hope I answered most of them during the break. In the next session, which will be in 2 days, also a pre-Christmas week, we're going to be talking about your regular old pneumonias and various types of viral, fungal, bacterial, and a few other considerations as well. So next webinar in 46 hours will be Pneumonia Day. And how about if we kind of close the whole thing off with our last song. And I think it's also a Phil Collins song. It's also a really, really great song. Here we go. I'm very, very serious when I say this. I'm not kidding around. Is it possible that we are in paradise already? But we are either just too stupid to realize it, or we haven't learned how to behave yet for paradise. Rock on, buzzards.